The real challenge for CIR is, sure, a couple of Saturdays in Midtown Manhattan learning about quality, fantastic. Who could argue about that? But the real challenge, here are the real challenges. So you've got to embrace transparency and accountability. You've got to make sure your practice, your hospital, your group, CIR for that matter, has total transparency and accountability. And we're headed to a world of no outcome, no income. That's all you really have to know about health reform. No outcome, no income. So it's all about what we measure, how we do it, understanding the systems nature of care, overcoming the cultural barriers of see one, do one, teach one, when in fact is it the right one in the first darn place? That's what we've got to do. How do we do it? Well, number one, going back to the definition of quality from 1991, we've got to practice based on the evidence where it's available. Maybe it's clinical decision support tools, maybe it's Isabel, maybe it's Zincs, maybe it's whatever EMR you use, but boy, we better get that evidence to us when we need it. Number two, reduce unexplained clinical variation. Well, we're only going to be able to tackle that with good measures. How do we know what works and what doesn't? The greatest predictor of utilization is the number of specialists available to do the test. Number three, reduce slavish adherence to professional autonomy. It's a fancy way of saying, hey, we're really good at this. Why should we change? Just ask any faculty member at Thomas Jefferson University Hospital. If you lined all 750 of us up and said, are we good, what would we say? We're awesome. But you have to help us accrue the evidence. Number four, continuously measure and close that feedback loop. That's where you guys come in. Hey, the third-year medical student took a 1-hour occupational history and knows something about that patient that you don't, that could be vital in your decision-making. So the power gradient, the communication skills, crew resource management from aviation, all of these new tools and technologies. And finally, number five, engage with patients like Jake Nash, good luck, across the continuum of care. Open access scheduling, email, tweeting, group visits, all of that with patients moving forward. That's where we've got to go. So let me close with a special plea about our School of Population Health. 2 minutes of shameless advertising. At the registration desk out back is our beautiful brand new brochure describing the only totally online master's degree in healthcare quality and safety. Now, do I expect every doctor to get a master's degree in quality and safety? Certainly not. What I do hope is that you'll join us in the journey. You'll take a course or two. Maybe you'll get a certificate. Maybe you'll become the expert teacher at your institution so you could then teach the teachers. That's the theme moving forward. The only way we're really going to move this leadership ball down the field is with some scholarship, some education, some research, some exposure to the core tenets, and then let 1,000 flowers bloom, so to speak, with all of you moving forward in a great movement across all of these amazing hospitals, all the delegates that are here today. Imagine the power of this movement. Will one school fix what's broke? Certainly not. But boy, are we committed, and am I personally committed, to being a core part of the solution rather than a part of the ongoing problem. And I challenge CIR to be a part of the solution as well. And again, I hope you'll go and grab one of our brochures. I hope you'll call me. I hope you'll email me. Some of you are already engaged with us. I'd like to have a CIR army of educated experts. Thank you. Really, really important.